Good afternoon, everyone, and welcome to Citywide Medical Grand Rounds. I'm wearing a slightly different hat today than usual. For those of you who don't know me, and maybe those online, my name is Shobha Sajana Kumar. I'm the chair of the Medical Grand Rounds here at Women's College, and as Dr. Harvey is away today, she's asked me to moderate this afternoon, so it's my pleasure to welcome you all to a very special installment of Citywide Medical Grand Rounds. It's our annual FM Hill Lecture. As you know, this event is recorded and it will be posted to YouTube for educational purposes. So by participating, you're all agreeing to being included in this recording. For those of you on Zoom, please keep your mic muted for us when you're not speaking, but it does enhance the experience if you leave your videos on, if your connection and your environment allow for it. At the end, we will open it up for a Q&A. So I will monitor the chat so people can post their questions and comments in the chat if they wish, or ask us the question. So I would like to start with a land acknowledgement. We'd like to begin with this acknowledgement of the land on which we work, study, and live. We recognize that many Indigenous nations have long-standing relationships with the land upon which the work of the University of Toronto's Department of Medicine is conducted. We acknowledge our presence on the traditional territory of many Indigenous nations, including the Mississaugas of the Credit, the Anishinaabe, the Chippewa, the Haudenosaunee, and the Wendat peoples. Today, this land is home to many diverse First Nations, Inuit, and Métis peoples, and we are grateful to have the opportunity to live, work, and gather on these territories. Land acknowledgements, of course, are only a starting point for larger conversations. More concrete acts of restitution and transformation are needed to address underlying inequities, and blatant discrimination in the distribution of resources between Canada's First Peoples and settlers. So this is a start. So in terms of our order of proceedings this afternoon, I think we have to start with an introduction of who Dr. F. Marguerite Hill was. This year, as in the past, we've invited our annual FM Hill invited lecturer to give the Citywide Medical Grand Rounds. The lectureship is held annually to honor this exceptional physician, mentor, and teacher, and our former physician-in-chief of medicine, who is here for 27 years at Women's College as teacher, clinician, and researcher, and for many of these years as our physician-in-chief as well. When she retired from Women's, her friends, colleagues, and patients established an endowment in her name, and through the generosity of these individuals, as well as Dr. Hill, this fund has grown tremendously, establishing initially the FM Hill Chair in Academic Women's Medicine, as well as the FM Hill Chair in Health System Solutions, and the FM Hill Chair in Humanism Education, the annual lectureship in medicine that we're about to hear, and 2 annual resident awards, one for mentoring and one for humanitarianism. So as in past years, I'm pleased to announce our awardees this year. We have Dr. Yusuf Al-Rodan, who is the recipient of the FM Hill Humanitarian Award. Step away. And then we also have Dr. Soo-Yun Shin, who is the recipient this year of the FM Hill Mentoring Award. Okay, so now we turn to our main event this afternoon. This year we have invited Dr. Lihi Eder to be our lecturer, and it is my great honor to introduce her. She's a clinician scientist at the Women's College Research Institute and an associate professor of medicine here at the University of Toronto. She was awarded Canada Research Chair in Inflammatory Rheumatic Diseases for studying barriers of equitable care in rheumatology, including the role of sex and gender as determinants of disease outcomes. She has a broad background within rheumatology with specific training and expertise in psoriatic arthritis, musculoskeletal ultrasound, and cardiovascular diseases in rheumatic patients. She's director of our psoriatic arthritis program and co-director of the University of Toronto's Cardio-Rheumatology program, which is an interdisciplinary program that aims to improve the management of cardiovascular morbidities in rheumatic patients by developing novel models of care and through research and educational activities. Her research efforts have resulted in countless peer-reviewed publications, and she is frequently invited to present the results of her studies at both national and international conferences. It is my great pleasure to introduce her as this year's FM Hill lecturer.
Okay, so good afternoon, everyone. It's a pleasure to be here. It's a huge honor for me to be giving this FME lecture for this year. And I also wanted to thank Dr. Paula Harvey for inviting me to give this lecture. So I'm going to be talking about cardio-rheumatology, which is an evolving interdisciplinary field in medicine. And we have developed this program that I'm going to be telling you about that is generating traction in cardiology as well as in rheumatology. And I think is very relevant to the legacy that Dr. Hill has left of interdisciplinary care. These are my disclosures. They are mostly related to educational and research grants and some advisory work in relation to pharmaceutical companies in the field of rheumatology. And you've heard about Dr. Hill. I just wanted to highlight a few additional points that I learned about her exceptional work and legacy. I learned that she opened a lot of doors to women in academic medicine. She was the first chief resident in Toronto General Hospital. As mentioned, she was the chief of medicine here at Women's for many, many years. And she also established a culture of interdisciplinary and patient-centered care that I think is very relevant to the talk that you're about to hear. And for her accomplishments, she was honored as being appointed as Order of Canada. And her legacy continues through several initiatives that you've just heard, including this talk that I'm very honored to give. So we are going to talk about inflammation and atherosclerosis, and there is a greater understanding of the pathophysiology and the key role that inflammation plays in the development of cardiovascular diseases. We now know that it's not all about cholesterol, that inflammation is very important in the development of atherosclerosis. Of course, we in rheumatology know that inflammation is everything, and I am happy that other specialties are starting to realize that as well. So inflammation plays a role in different stages of atherogenesis. Of course, cholesterol is key in triggering the initial insult to the vessel wall, but then there is an accumulation of inflammatory cells within the vessel wall, and this is associated with the development of atherosclerotic plaques. And these plaques becomes more inflammatory, can become inflammatory in nature, which makes them more vulnerable for rupture, and a rupture of plaques lead to acute events like myocardial infarction and stroke. And this concept of inflammation being a causal factor in the atherogenesis is gaining a lot of interest, especially when it comes to targeting inflammation. And in recent years, there has been a few key clinical trials that attempted to target inflammation as a way to reduce cardiovascular events. The key or first pivotal trial in this area was called CANTOS, and CANTOS was a study that attempted to reduce cardiovascular events by targeting IL-1, which is a pro-inflammatory cytokine, using a medication called canakinumab that blocks this pathway. Canakinumab is a biologic treatment that we use in rheumatology for gout and autoinflammatory conditions. But in this case, they've used it in patients without any rheumatic disease, and they randomized them into canakinumab and placebo. And they were able to show that among patients who did not have any rheumatic condition, canakinumab was associated with a reduction of myocardial infarction and stroke or MACE. So this was a first proof of concept study. And then came along additional trials in this field, and especially two large studies that used colchicine as a way to, again, target inflammation and try to reduce cardiovascular events in non-rheumatic patients that are at high risk. So these are people with established cardiovascular diseases. And one of these studies was from Canada, led by Dr. Tardif, and the other one was an international study. Both of them were positive studies showing that colchicine can be used in high-risk individuals here, in the case of secondary prevention, to reduce cardiovascular events in patients who are already maximally treated for their cholesterol and hypertension. So targeting inflammation in addition to traditional cardiovascular risk factors seem to be a good strategy in high-risk individuals. And these studies led to the approval of colchicine for prevention of MACE in patients with established cardiovascular diseases. And this is a very interesting way of repurposing a medication that is an old drug that we use in rheumatology for many, many years to treat, again, gout and other autoinflammatory conditions. So there are now many other studies, RCTs in the field of cardiology, looking at different pathways, immune pathways, trying to reduce cardiovascular events, targeting different parts of the immune system. So these studies and additional understanding of the role of inflammation led to the concept of trying to reduce inflammation as a way to improve cardiac health or reduce cardiovascular diseases. And this is gaining acceptance in the field of cardiology. And as a side note, I see some of my cardiology colleagues here. I enjoy working with my cardiology colleagues. They're like superheroes, right? They can fix everything. They can open blockages. They can fix the electricity. We rheumatologists are a lot more modest. We can increase prednisone, decrease prednisone. We are a lot more modest in that sense. But I want to say to my cardiology colleagues, it's about time that you understand that inflammation is important in atherosclerosis. We knew about it for many, many years. And this is an example. This is a study that was published in 1978 by a few members of our division of rheumatology, U of T. This study was led by Dr. Murray Jurovitz, who is still an expert in lupus, and they've described for the first time a bimodal mortality pattern in lupus patients. So they've shown that patients who survived the first insult of lupus died very early on due to myocardial infarction. And you can see these are premenopausal women who died of heart attacks before menopause in their late 40s. And this is really one of the first studies that established this, the fact that cardiovascular diseases are increased in patients with inflammatory rheumatic conditions. And since then, there's been multiple other studies and a lot of literature in the rheumatology field showing that essentially any rheumatic condition that you will study is associated with an increased risk of developing myocardial infarction, stroke, and many other cardiovascular events. Most studied is rheumatoid arthritis with 50% higher risk, but also psoriatic arthritis and even osteoarthritis, which is considered to be not inflammatory or systemic inflammatory condition, is associated with increased cardiovascular risk. So the burden is high in the patients that we see in rheumatology. And I wanted to share some data from our own research in relation to psoriatic arthritis. Psoriatic arthritis is an area that I'm focusing on clinically and as well as in research. And this is the second most common type of inflammatory rheumatic disease. It affects about a third of the patients with psoriasis, and it is associated with both musculoskeletal and skin inflammation, as you can see in these pictures. But it's also associated with obesity and related metabolic abnormalities. So psoriatic arthritis can serve as sort of an in vivo model to study the intersection or interaction between inflammation and cardiometabolic abnormalities. So this image is just to illustrate the fact that psoriatic arthritis is more than just skin and joint inflammation. It is a systemic disease, and this is a PET scan and showing here increase in FDG uptake of in certain organs. It's showing essentially increased metabolic activity in the heart, in the liver, in the subcutaneous tissue, as well as in the aorta, in the patient on the right-hand side compared to the control patients. And just illustrating very nicely the fact that we need to think about other systems, not just the skin and the joint inflammation. So some research in this area, we've used the University of Toronto psoriatic arthritis cohort to study risk factors for the development of cardiovascular events in this population. This is a cohort that was established by Dr. Daphna Gladman in 1978. It's a longitudinal cohort that includes a lot of clinical information as well as information on comorbidities. And we were able to use this large cohort to show first that up to about 20% of the patients developed cardiovascular events by the age of 70, so not a rare event. As expected, we see that males start to develop these events about a decade before female patients. Females start to develop it usually after menopause. And when we looked at risk factors, you can see that, as expected, we see that traditional risk factors like smoking, hypertension, diabetes are important. But when we control for these factors, we can see that other disease-related factors, especially dactylitis, which is a sausage digit, which is a marker of inflammation in PSA, as well as high SED rates, these are associated with additional risk of developing in cardiovascular events. So it's a combination of traditional risk factors as well as disease-related inflammation that predispose individuals to develop these events. Another way to study this is by using vascular imaging. We used carotid ultrasound and we measured the presence of plaques, and you can see here a plaque in the carotid artery. The plaque is a surrogate measure of future risk of developing cardiovascular events. So we use this and we use the cohort information to show again that both demographic factors, age, sex, as well as cardiovascular risk factors are important, but also the burden of inflammation over time. So DAPSA is a way to measure disease activity, the arthritis, the skin activity in patients with PSA, as well as other laboratory measures of inflammation like SED rate and white blood cells count are associated with elevated risk. We also used some more advanced testing of cardiac biomarkers, and troponin is a known measure of cardiac injury, and NT-proBNP is a measure of cardiac strain. They're commonly used in clinic. And we use this in patients that were seen in our cardio-rheumatology clinic. These are asymptomatic patients without a history of cardiovascular events. And you can see here that over 20% of the patients had elevated troponin. These are patients above the age of 65, and over 30% had elevated NT-proBNP. So these are asymptomatic patients showing some signs of cardiac injury and cardiac strain. And why is this important? Because when we looked at the cohort of psoriatic arthritis patients, we showed that patients with elevated cardiac troponin and cardiac NT-proBNP are at increased risk of developing future events. And this was independent of traditional risk factors. So even after we adjusted for the Framingham risk score, these patients were at high risk of developing these events. This is a study that Keith Colasso was doing when he was doing a PhD with us. So I showed you that inflammation is important. So what about suppressing inflammation as a way to reduce the risk? And we studied this again using vascular imaging. We used two methods of assessing the burden of atherosclerosis in patients. First, we used carotid ultrasound and measured the size of plaques. And we also used FDG PET scan. This was in collaboration with a group at the NIH. And we evaluated patients who were treated with TNF inhibitors. TNF inhibitors are the first class of biologic therapies approved for the treatment of psoriatic arthritis. They are very effective in controlling skin and joint inflammation. And we showed that in patients who were treated with TNF inhibitors, there was less progression of plaques and there was a reduction in the vascular inflammation. So seemed to be a protective effect of treating inflammation, not just to control the skin and joint inflammation, but also potentially to reduce future risk of cardiovascular diseases. So there is a lot of interest in how the different biologic medications that we use in rheumatology influence cardiovascular risk. We had a revolution in the field of rheumatology over the past 20 years or so with introduction of a lot of biologic therapies that are targeting specific components of the immune system, in addition to more conventional and older medications that are still available and used, like methotrexate, and of course, corticosteroids and NSAIDs. And the different medications, they are all effective for inflammation, but they might have different effects on the metabolic abnormalities as well as cardiovascular risk. And I'm going to show you a few examples because this is a really long topic. I just wanted to touch on a few aspects. So corticosteroids, we know corticosteroids are still commonly used in rheumatology. They are used usually as sort of a bridging or to treat flares. We try to minimize the use of corticosteroids because we know that they are, even though they are very effective, they are associated with a lot of side effects, specifically weight gain, dyslipidemia, hypertension, and many studies have also shown that use of corticosteroid is associated with an increased risk of developing cardiovascular events. But sometimes it's very hard to get patients completely off prednisone. And so the question is, what is the safe dose? Is there a safe dose? And this is a recent study showing that a dose of prednisone of less than 5 milligrams seem to be safe and seem to carry similar risk in relation to cardiovascular events. So this is something that we as rheumatologists are trying to minimize use of corticosteroids, and these lower doses seem to be relatively safe. TNF inhibitors, I mentioned before, are still the most commonly prescribed class of medications in rheumatoid arthritis and psoriatic arthritis. And there's been quite a lot of studies showing that there is a protective effect, or at least no worsening of cardiovascular risk. These are mostly observational studies because it would be obviously unethical to leave our patients without treatment just to study the effect compared to placebo. But it is reassuring to see that all of these or these meta-analyses seem to be consistent, showing a reduced risk of developing cardiovascular events compared to placebo or compared to conventional DMARDs in relation to major cardiovascular events. What about IL-6 inhibitors? So IL-6 inhibitors are medications that are used in rheumatoid arthritis, most recently also in polymyalgia rheumatica. And we know that IL-6 is a key cytokine in the pathogenesis of atherosclerosis. It's associated with plaque burden, with an increased risk of fracture, and it's of course also associated with arthritis. So potentially targeting IL-6 should be protective in relation to atherosclerotic events. However, one concern that was raised was the increase in cholesterol, both LDL and HDL and total cholesterol, when used in the context of rheumatoid arthritis in trials. So, of course, this raised concerns about future potential risk of events in these patients. And just to spend some time on this association between inflammation and lipids, because this is a unique feature that you see in rheumatic patients. It's called the lipid paradox, and it's relevant to the IL-6 inhibitors as well as to other biologics. Generally, you can look at the graph here and see that there is an inverse relationship between the levels of LDL and the level of arthritis or inflammation. When patients have high level of inflammation, the lipids tend to be lower. And when patients get into remission, there is an increase in the LDL and the total cholesterol. The reason for this is not entirely clear, but it's possible that this is related to energy, the needs of energy to produce more immune cells in the periphery. So these are shifts in the levels. So essentially, when a patient is in remission, this is probably reflecting more the baseline levels of lipids in a particular patient. This is also explaining this graph here on the right-hand side that is showing that in contrast to what we see in the general non-rheumatic patients where LDL levels, elevated LDL levels are associated with an increase in the risk of cardiovascular events, in patients with rheumatoid arthritis, especially in older series, we don't see that increase here. We just see a flat line. And this is because of the role of inflammation. When a patient has high level of inflammation, the LDL is lower, and inflammation is associated with increased cardiovascular risk. So this is kind of disrupting this expected relationship. The take-home message for the clinician is that if you measure lipid levels in a patient with rheumatoid arthritis or any rheumatic condition, measure it when they are in remission in a steady state, because this will be more reflecting the true status of their lipids. So going back to the IL-6 inhibitor story, the FDA mandated this safety trial to see whether this elevated lipids is associated with an increased risk, and they enrolled patients who were at high risk of developing events. These were RA patients, older, with at least one cardiovascular risk factors, including some patients with an established cardiovascular disease. And they randomized them to tocilizumab, which is an IL-6 inhibitor, and to etanercept, which is an TNF inhibitor. And the outcome was MACE, and they showed that there was absolutely no difference in the risk. So you can see the hazard ratio is almost 1, showing that these IL-6 inhibitors, despite of that increase in lipids, this is not translated to an increase in cardiovascular events, probably because the beneficial effect of reducing inflammation very effectively and the shift in the lipids is not necessarily all bad. There are some functional changes that are happening in the lipid metabolisms that are not carrying the bad effects. But not all suppression of inflammation is good, and we learned this from another medication or another class of advanced therapy, the JAK inhibitors. And if you're a rheumatologist, you probably have heard about this many, many times. But if you're not, this is the oral surveillance study. This is a safety trial, again, mandated by the FDA because of some safety signals identified in tofacitinib trials. So tofacitinib is a JAK inhibitor, and JAKs are downstream molecules that block these pro-inflammatory pathways. So unlike the cytokine inhibitors that are more upstream in the cycle, these are downstream and they block several different pathways. So in a sense, their effect might be less expected. And in these early trials, they were showing that there is some signal for increased risk of MACE as well as VTEs. So this was mandated to compare tofacitinib, JAK inhibitor, to TNF inhibitors that we know is safe in patients with RA that are at high risk, again, above the age of 50 and with at least one cardiovascular risk factor. This was designed as a non-inferiority trial, meaning that the hypothesis was that tofacitinib is as safe as a TNF inhibitor, and this study failed to meet its primary endpoint because you can see that these 95% confidence interval crossed the 1.8 line, which means that we cannot say that they are the same in terms of safety. So JAK inhibitors receive the black box warning when it comes to cardiovascular risk. So it means that in patients, especially patients above the age of 65, patients who smoke, patients with established cardiovascular disease, these medications would not be the first line. And if we do prescribe them, we need to think carefully. We need to discuss the risk with the patients. And essentially, it means that rheumatologists need to do cardiovascular risk stratification and think about cardiovascular risk factors in our clinic. So overall, this is quite a complex system. I hope I demonstrated that there are many factors here. There is inflammation itself that is not good for the heart and the blood vessels. There are traditional risk factors that are quite common in our patient population: obesity, lack of physical activity, smoking, and other risk factors. And there is the effect of medications that we prescribe that can be good or can be bad. They all suppress inflammation, but they can have some unexpected effects on the heart directly or on traditional risk factors. So we need to take these into consideration when we also study this. We need to think about a lot of factors, and we could benefit from understanding of these different factors, both from the rheumatologist and the cardiologist. So how do we identify those at high risk? I just showed you that we have to identify them because that can inform the selection of biologics, but it's also important for us to manage traditional risk factors in these high-risk individuals. So traditionally, cardiovascular risk stratification is done by scoring systems like Framingham risk scores and others. But studies have shown that they don't function as well in patients with rheumatic diseases as they do in the general population. And you can see this example in patients with psoriatic arthritis, showing that the observed risk is higher than the predicted risk. And the reason for this is probably because these prediction scores were developed in people in the general population, and they don't take into consideration the fact that inflammation plays a role. It's not factored into the calculator. And it's important because if we underestimate the risk, of course, it means that some patients might not be prescribed medications that they need because their actual risk is much higher than we think it is. So this is an example of a calculator. And in order to account for this unmeasured risk, there were a few suggestions by societies. The EULAR is the European Society in Rheumatology, and also the American National Psoriasis Foundation. They suggested using a multiplication factor of 1.5 to account for that unmeasured risk. Why 1.5? This is an expert opinion. It's not based on data, but because of the roughly 50% higher risk, they suggested this 1.5 cutoff. So this is an example of how it's done. If you calculate the risk, you multiply by 1.5, and this may mean that the patient may move from a low risk category to a high risk category, and that may mean that they need to be prescribed, for example, statins because of this change in category. Another way to try and identify these high-risk individuals is by using vascular imaging. I showed you the carotid ultrasound that we do in clinic. And we've studied in our cohort over 500 patients that underwent carotid ultrasound. And we show that if you have plaques in both of your arteries, you're at a high risk of developing these events. And importantly, this was independent of traditional risk factors of Framingham risk score. So it can serve or provide additional predictive value and can reclassify patients into the correct risk category. And so this is one easy way of doing it. Of course, there are other vascular imaging modalities like coronary calcium score that we use in the cardio-rheumatology clinics and others. So these should be considered also in rheumatic patients, especially those in intermediate risk categories where we are not sure if, for example, if you want to prescribe JAK inhibitors and I'm not sure, I might send them to do these imaging modalities. So in the last part, I wanted to spend some time telling you about our cardio-rheumatology program, because the term cardio-rheumatology is an evolving field, especially gaining more attention in cardiology. And this is really sort of the background behind it. We just shown you the importance of managing cardiovascular diseases in rheumatic patients, and recommendations were sort of controversial regarding who is responsible for managing these traditional risk factors. These are the EULAR European guidelines, placing all of the responsibility for managing cardiovascular risk on the shoulders of the rheumatologists. But this is a problem. Why? Because there are many barriers within the setting of rheumatology, and this is a study that looked into some of these. We in rheumatologists, we don't have time to do it. We have very complex patients. We have so many other competing tasks that we need to complete in a short period of time. There is also lack of knowledge. Many of us it's been many years since we finished internal medicine, and most of us are not very up to date in terms of the most recent guidelines in hypertension, diabetes, cholesterol, and others. It's also not clear who is responsible, and there is a lack of care coordination between GPs and rheumatologists with respect to the management of cardiovascular risk factors. So there are many barriers, and these barriers lead to underdiagnosis and undertreatment. This is an example of a study that we've published, studying over 2,000 patients with psoriatic arthritis that are seen in 5 large academic centers in North America. And you can see first that there is a huge burden of modifiable cardiovascular risk factors. Most of the patients that we see in the clinic have at least one of these modifiable risk factors. There is also a significant proportion of the patients that had dyslipidemia that were not aware of the fact that they have dyslipidemia, or hypertension that were not aware of the fact that they have hypertension. So many of the patients that we see in clinic, they either don't have GPs, many of them are not aware of the fact that they are at increased high risk of developing these events. They think that when we order blood tests that we measure everything and we automatically take care of all of these needs. And for many of us, we are the main source of clinical care, we in rheumatology. So in practice, there are significant gaps. And this led us to put together this program, the Cardio-Rheumatology program, and this started in 2017 as an interdisciplinary collaboration, we've written an editorial about this, the need to collaborate. This is Paula Harvey, Dr. Harvey, and myself published this editorial in response to the guidelines that were published by EULAR, suggesting that this task should not be placed solely on the rheumatologist's shoulder. It should be more collaborative care. We should build these bridges between cardiology, rheumatology, and primary care to better manage our patients. Rheumatologists are experts in treating inflammation. We know how to choose the best drug to control the inflammation. We can manage the corticosteroids, reduce the dose of corticosteroids. We can prescribe NSAIDs. We can also screen traditional risk factors, and we can educate the patients. But managing the cholesterol, the hypertension, the diabetes, these we believe should be done in collaboration with either primary care or cardiologists that are well more experienced in this regard. Cardiologists especially are also important in managing more complex cases of hypertension, dyslipidemia. They are experts in ordering more advanced testing, vascular imaging testing, as well as, of course, investigating symptoms of chest pain and other symptoms that might be associated with cardiovascular risk. So I wanted to tell you a little bit about the University of Toronto Cardio-Rheumatology program. This is a program that I mentioned started in 2017 with the aim to improve the management of cardiometabolic diseases in patients with rheumatic diseases. It has 3 main domains. The main one is patient care, and we have a primary prevention clinic here that I'll tell you about. The aim here is to prevent cardiovascular events in rheumatic patients. We also are a referral center for more complex cases of severe cardiac involvement, lupus or vasculitis or other rheumatic diseases that may manifest as heart diseases. We also do research. So patients that we see in clinic are enrolled in a longitudinal cohort, and we collect information in a standardized way. And the idea here is to understand the mechanisms that are underlying these events and also try to identify better ways of risk stratification and identify the best tools to identify high-risk individuals so we can intervene early. And finally, we also do, we emphasize education. So we have several knowledge transfer activities, as well as training the next generation of clinicians and researchers. So I wanted to just highlight a few of the individuals that are key in this network. So myself and Paula Harvey are co-directors of this network. Dr. Shadi Akhtari, who is sitting here, is key in running the primary prevention clinic. Dr. Akhtari is a cardiologist, and she's also expert in primary prevention and cardiac imaging. And she's seeing the patients in the clinic and managing their cardiac risk and cardiac diseases that are identified. I also want to acknowledge the rheumatologists that are part of this team, Dr. Dania Jerome, who is sitting here, and Dr. Bindi Korea from Sinai Health. So this is a true inter-institutional collaboration within U of T. And Dr. Elsie Nguyen is a vascular radiologist who is helping us with all the vascular testing that we are doing. I also wanted to mention Keith Colasso, who finished a PhD with us and is now managing our educational activities of this network, and Famin and Sohan, who are sitting here as well, who are managing all the research related to this network. So what do we do in clinic? We get referrals from general rheumatology, both from the university hospitals as well as from the community. We accept referrals of patients with inflammatory rheumatic diseases above the age of 40 without any history of cardiovascular events. These patients are seen in the clinic. They are seen by the cardiologist. They get a thorough assessment of their history and physical exam, and we have a variety of testing that we perform, including vascular testing and more advanced cardiac and lipid biomarkers. After having these tests, they're being seen again by Dr. Akhtari, and she makes the recommendations regarding managing their cardiovascular risk factors based on their results. And then we do a short and long-term follow-up assessments at 1 year and 5 years just to see what has happened and to reinforce the recommendation and assess the adherence. And we hope that with this, we are able to improve their care. And I wanted to share a few very crude numbers. So since 2017, we've seen over 700 patients. As you can see, about 60% of them have rheumatoid arthritis, about a third psoriatic arthritis, and the rest are axial SpA. You can see also that the burden of metabolic abnormalities is quite high. So almost 40% of the patients are obese. Half of them have hypertension. 25% have dyslipidemia. By definition, all of them have rheumatic diseases, and most of them are seen at a steady state or in low disease activity state. But despite that, you can see that almost 40% of the patients have elevated CRP levels. So meaning that the level of inflammation is high. And almost 20% of the patients had established cardiovascular disease if you consider coronary calcification as a way to measure it. So a score of more than 100 is considered to be high, and 20% of the patients that we see in clinic that are asymptomatic and don't have a history have a coronary calcification. What about recommendations? So you can see that based on these, a significant number of patients required change in care. Over a third required new prescription for lipid-lowering therapy. 20% required new prescription for antihypertensives. And 8% were prescribed aspirin. There are a variety of other changes that have been made. We just don't have enough time to tell you about all of these, but I just wanted to share a case of one patient that I think illustrates everything I told you very nicely. This is a patient, 57 years old, retired railroader from rural Ontario that is being followed here in rheumatology. He has a rheumatoid arthritis for 4 years. He's very stable from the point of his rheumatic disease on methotrexate and golimumab, which is an TNF inhibitor. And apart from being an ex-smoker, he doesn't really have any other traditional risk factors. And you can see that the calculated score is quite low. So this patient would be placed in a low risk category from point of future cardiovascular risk. But when we did all the testing, these are all standard tests. You can see that he had very elevated coronary calcium score. Remember, over 100 is considered to be high. He also underwent exercise stress echo. Again, this is a routine test that we do, and he was found to have transient ST elevations while he was exercising. And he was rushed to the coronary cath lab and was found to have quite a severe blockage of the mid-LAD. I'm told this is bad, right, Shadi? And he underwent PCI and he's doing well. So this is just to show that the traditional way that we're using for assessing cardiovascular risk in the patients that we see in clinic may not work for many of the patients with these unique diseases. And we need to find better ways of managing this risk. So a few last points. We do have a website. If you're interested in learning more, this is available for you to see what we're doing, publications, events. We have an annual symposium, Cardio-Rheumatology Symposium, held every year, and it's well attended. We try to update on recent advances in the field of cardio-rheumatology. We have international speakers, and if you're interested in hearing recordings from previous years, these are also available in the website. We also learned that many patients that we see in clinic are unaware that they are at elevated risk. So we developed some educational materials. These are pamphlets that are disease specific and provide some additional information about their risk and why they are at high risk and what they can do to potentially reduce their risk. We believe that empowering patients by providing them information is important. They can serve as advocates for themselves beyond the care that they receive in clinic, also potentially educating other care providers. And we also try to transfer this knowledge to our colleagues and to the general population through articles and interviews. So I'll end here. I just wanted to summarize inflammation and cardiovascular disease are strongly linked. We now know that control of inflammation is important to reduce cardiovascular risk in the general population, but it's also very, very important in the patients that we see in rheumatology. And I think that the lessons that we learn in rheumatology from many years of using biologic therapies, different pathways that we block in the immune system could also serve as sort of as in vivo models to understand atherogenics in general. And in terms of patient care, I think cardio-rheumatology is gaining more attention, and interdisciplinary care is really very important to address existing gap. We can't do it alone in rheumatology. We need the help of our colleagues to better manage these important comorbidities. So I really wanted to thank all of my colleagues. It's been really a joy working with my colleagues in cardiology and rheumatology. All of them are listed here, and many other collaborations that I have across the university and outside of it. And also wanted to thank the support that we get from funding agencies, and thank you for your attention.
Thank you, Dr. Eder. That was a tour de force. There are a couple of questions, comments in the chat that I will read out, maybe to start with, and then we'll open it up to the audience in the room. The first question in the chat, someone asks, does JAK inhibitor-induced hyperlipidemia warrant treatment in patients with a low cardiovascular risk?
Okay, so yeah, I think so. As I mentioned, JAK inhibitors in general, they do can induce or not induce may not be the right word. They suppress inflammation very well. So as I've shown, when the inflammation is suppressed, the lipid level are just going back to the steady state. So if you have a patient with elevated lipids and they need to be treated. The mechanism where by JAK inhibitors induced cardiovascular or associated with increased cardiovascular risk is not entirely clear. It may not go through the lipids. It may be through increased tendency for thrombosis. So this is sort of a more complex understanding. So besides managing traditional risk factors, rheumatologists need to consider the other profiles, whether the patient is smoking, whether they have established cardiovascular risk, cardiovascular disease, and other factors. So it's not just the cholesterol.
Low cardiac risk, I guess, in this population is not necessarily low cardiac risk. Yeah. There's also a question from someone who says, as a longtime patient at a psoriatic arthritis clinic, having recently had a triple CABG, how would they get referred to the cardio-rheumatology? Thank you.
I wish we could, I wish we could prevent it. I mean, as I mentioned, we are mostly focusing on prevention in our clinic, and patients that already have a cardiologist, we cannot, unfortunately, see everyone, and people that already had the event are probably better managed by their current cardiologist.
Totally fair. From the room, do we have any questions, comments?
Thank you for a great presentation, Lihi. As a general cardiologist, I'm interested in seeing how the lessons from this group of patients apply to people who don't have diagnosed rheumatologic disease. And in the general cardiology community, as you know, Paul Ridker kind of went down this path, but he chose to use canakinumab. If, knowing what you know now, if you had to do this, would you choose that drug, or do you think there are other better options to develop a program to reduce inflammation instead of general population?
You want to paraphrase, or should I?
Yeah, so the question was about a question from cardiologists and understanding which medications were to use to reduce cardiovascular risk in the general population, and referring to the canakinumab with Canto study that studied canakinumab and IL-1 inhibitor, whether this was the best medication or was something else preferred. I think, well, the canakinumab, even though it was positive, as you know, it had other issues. First, obviously, the cost, and also some risks or adverse effects that were more common, like infection, were a lot more common with this particular agent. So I really can't tell you. I think we in rheumatology, we have better biology. IL-1 inhibitors is not a common medication or biologic that we use in rheumatology. They are certainly more effective medications, especially when we are referring to the inflammatory rheumatic diseases, even though IL-1 inhibitor is key. I think in cardiology, they tended to focus on the NLRP related pathways. So IL-1, colchicine, of course, is very also blocking pro-inflammatory pathways related to the NLRP, and IL-6 as well. I think the concerns with IL-6 inhibitors were the elevated lipids, but I think this might be an alternative, and I understand that there are trials looking at IL-6 inhibitors. So I think right now it's focusing on these particular pathways, and specifically when targeting a single cytokine, it's easier to maybe learn lessons from rheumatology trials and what we know in rheumatology, and the profile of side effects is more maybe predictable compared to when you block downstream effectors like JAKs or TYK2 or others that block multiple pathways, and it's kind of hard to predict what is going to happen. But I think that the medications that already are used or has been tested in rheumatology trials could teach about potential, maybe mostly about the safety, because I think in cardiology, you might be treating a much larger group of patients and exposing them to potentially harmful effects of these medications. So thinking about the adverse effects is also key in this regard.
Wonderful to have your clinic here. As a family doc at Women's, I've got the luxury of being able to refer to you. When I think about Ontario patients and their family physicians, the newly diagnosed inflammatory arthritis patient with no known cardiac disease would be a very common presentation, would totally overwhelm your clinic. We need to go broader. You commented about Framingham and then looking at having a 1.5 multiplier there. So this is the first time I've ever heard of this, which is wonderful. But I'm wondering, for the group here and cardiologists in the crowd as well, is there work underway to revise Framingham to take this into account? As a family doc, I've got hundreds of guidelines I'm supposed to be following. I need simple tools for my simple mind. I like the Framingham. It works for a lot of things, but clearly not here. Any sense of when a modified Framingham might be available for this group of patients?
So there are other formulas, actually, not just Framingham, and there is a more a newer formula that was developed by the American Heart Association that is more commonly used in the US, I believe. But there are formulas that actually incorporate CRP into it, or whether a patient has rheumatoid arthritis, but they have not been shown to function better than the Framingham in this particular group of patients. So at this point, applying the 1.5 multiplication factor might be reasonable. I think the other aspect is that cardiology guidelines are emphasizing, or there is a list of conditions that are clinicians should be regarding these patients as at risk, or it's a risk enhancer. So people with rheumatoid arthritis, lupus, psoriasis. So it means that, for example, if you calculate the risk and the patient is in an intermediate risk group, you may need to address them more aggressively, or to do a coronary calcium score or something to inform you whether they need to be treated more aggressively and not just like anyone else.
Okay, sorry, everyone. I can see who is posting things in the chat, but not who had their hands raised on Zoom. Dr. David Jenkins, I think, has had his hand up on Zoom.
Thank you very much. Lovely talk. Thank you. My mind went back to when Paul Ritker came up and lectured us at St. Mike's just after his publication. And so we said, well, you're going to be doing very well with NIH now. And he said, no, because the cancer people are now, because of our lung cancer benefit, are now getting all the funding. So I wondered, you've gone into the cardiovascular, will you be big time into the cancer too?
So the question of Dr. Jenkins is whether we are going to go into the cancer field too, because cancer is obviously also a group of diseases that have been associated with increased cardiovascular diseases. And for me, definitely, this is beyond the scope of what I can do, but there is a society for cardio-oncology, right? That's the right terminology. And these are people that are investigating, similar to what we do in cardio-rheumatology, the links between cancer and cardiovascular events and the effect of medications for cancer, treatments for cancer, and the effect on the heart. So definitely this is a field that is already established. Thank you.
I suspect we could go on. Sorry, everyone, in the interest of time, I think I'll have to close this. Thank you very much, Dr. Eder, for a brilliant talk. Thank you, everyone, for being such a patient audience. Nish, how do I turn this off? I just wanted to not create the noise again. On behalf of the Department of Medicine, Dr. Eder, if you want to.
Thank you so much.
Thank you, everyone on Zoom as well. And everyone, please fill out the evaluations.
I think all my officers, you know,